Thank you. I'm happy to be among yourselves today. I've seen a few people that I know from way long back. Some were my teachers, some classmates, some schoolmates. So it's the right place to be at. Never mind what Pamela said about fighting for the organ. Right. So in history, when there is a movement or there is a cause, people need some rallying points all over history, all over the world. You need a rallying point. You need emblems to share, things which are easily recognizable, things which are easily vocalized, or which you can see and you recognize, like a flag or a slogan. So I'm going to talk about such a thing today called the B-RAS. Is the way that we are looking at breast care at the UBH, but we are now extending to the Matabeleland South Province. Currently, just affecting the corridor, Gwanda and Beitbridge, but we hope to increase our reach as long as there is uptake. So the mother to this B-RAS is a partnership between the UBH and ABS. ABS stands for Association of Breast Surgery of the UK. We started a partnership about 6 years ago, and the B-RAS concept only came on about last year as we realized that there was need to engage the community of practitioners. There was need to engage the community of ladies and their families. Right. I was trained in oncoplastic breast surgery. You may wonder what that is. Right. What it is essentially we remove tumors from breasts, and with the aim of wanting to, at the end of it all, have a breast that is recognizable, in shape or sometimes even in function. So, but I'm not going to talk about the techniques today. However, there are principles which we can draw from the practice of oncoplastic breast surgery as we go along. Right. As we're talking about rallying the community around, there are possibilities of being misunderstood. There are possibilities of misunderstanding on the part of the people, particularly who are supposed to be the beneficiaries, people who stand to benefit. They may not realize the outcome of the help that you are proposing for them. So today, I hope I will be understood by this audience. I want to engage you in a way which, at the end of this all, I think we'll move together in advocating for women's breast health. Right, as you can see there, surely there's no way that this lady would have realized that the outcome of the proposed procedure was going to end up with what is, the other picture. It's the same patient, as you can see. So this is before and after. So there's ambiguity when you are proposing something new. As a matter of fact, earlier this year, we had a stand at the ZITF, and the stand here, the banner for the B-RAS project. And we became so popular, and there were many people who were coming to the stand, and we wondered why it was so. And do you know what the answer is? It's because they thought we were selling women's undergarments. Because of what we are moving about with. So there's that ambiguity which we need to tolerate as we go along. Right. The other thing that you realize, the other principle that you realize, that as you are proposing something new, you may need to do it a number of times. Right. So this is a picture which you saw at the beginning, and now the right is the patient after the procedure was done. But closer look, you realize that the skin around the nipple area still needs some touch-up, which probably would do after a year when everything is settled. So there may be need to repeat. And I'm saying this so that probably you can invite me again to talk to you and about this same concept. Because this patient probably will do the operation a year from now. So when you invite me again, probably I'll give you a more recent picture by that time. Right now to the matter of our discussion. Breast cancer is on the rise globally, and you are aware of the how it stands relative to cervical cancer in this country, but that terrain is changing because of the HPV introduction, the HPV vaccine. So I think it's a matter of a few years, and then it will be breast cancer at the top of the problem malignancies in this country. So what shall we do when we have a monster that is coming to attack us all as a community of practitioners and as a community, the wider community of people? Right? That's not the only issue that the breast cancer is actually on the rise, but we have got a unique problem in that the setting is different from what probably you get if you Google about breast cancer epidemiology. We are in a place where most of our patients are in the reproductive age group. Comparing with the UK or other places, we have the problem at a much earlier stage, and therefore the method that they've used there may not be applicable here. Because, take it, the woman's breast undergoes changes as she grows. So in the younger age group, of which our women who tend to have this problem tend to be younger, their breasts are so dense, and therefore mammography will not be useful or that useful for all of them. So we need to develop a way, an appropriate technique to do early detections and also to manage the problems. Never mind the fact that we don't have many mammogram machines anyway, which they have. So, and as well, the ministry, I saw there was somebody from the ministry. There is no comprehensive structure for this condition as has been developed for cervical cancer already. So I mentioned about the ABS UBH partnership, which has been in existence since 2018. And we are working around to see if we can drive up awareness and enhance efficient diagnosis, and also make sure that all the patients who are diagnosed with breast cancer go through full treatment. Right, so what does the concept entail? There are 4 items, as you can see, and 3 of them relate to the empowerment of the patient or the empowerment of the woman before she even has a problem. Right? We advocate what is known as breast awareness. Is basically knowing your breast in health. And if there are any changes that you notice, which on the full B-RAS poster, we have put them down in a pictorial form, the things to look out for. So any deviation from the normal to those changes, the woman must take note of that. But not only that, she must ask for professional help. Those are the things for the patient. Now the 4th aspect is what we are here for, to try to appeal to you. Probably you may be of help to the patients. You attend to their genital system, all fair and fine, but it's a sad thing if such a woman comes to you with an unknown problem in their breast, which they're not aware of. And then they're going to die when you have actually attended to their gynae system and they've done well with respect to the pelvic structures. So the S is what we are here for. So you don't need to be trained in breast management. If you are, it's fair enough. But importantly, just sometimes to give information, say, okay, the person who can handle this kind of problem is found round about the corner or at such a hospital. It's good enough, just signposting. If you know how to assess and to do it properly, then it's okay. It's good as well. But the S is actually, it takes doctors, it takes, of every level, any level. It takes in nurses, the support that you pledge to give, and it takes even the community health workers whom we are going to reach out to according to our project, which we are doing in Matabele and South. We also want to get that far out. and as long as they're able to give some information around breast, we are happy with that. So the S encompasses a number of people. Right. So within the network at the moment, as I mentioned, we have the UBH, where we have a well-developed clinic now, which has managed to cut down the time to diagnosis to about a week to 2 weeks, where, from the time that a woman comes into the clinic, we assess them, we do the scans, and we're able to take biopsies sometimes on the same day, and that has cut down from the many months that it used to be now to a few weeks. So at the UBH, we are set. We've now recently gone down to Gwanda and connected the scanners which we use, and they've started sending pictures, and we're discussing and we're managing, kind of planning the management with the teams out there. So now we are at your points of interest. Right. What are the touch points, the times that you are likely to see women and they will be very receptive or are likely to be receptive to the idea of either having their breasts examined by yourselves or to be referred to the necessary place where they can get their help. So there are a few such points which I've outlined, which are open to discussion, but I think this would be a starting point. Number one is the family planning clinics, right? In the disease process for breast cancer, we know that the majority of them, 70%, 75%, they are estrogen receptor positive, and therefore they can be affected by any hormone that you can give to the woman, however you give it. Whether it's a Jadel, whether it's the pill, the mini pill, any of those which have got hormones, they can actually affect the prognosis in breast cancer. So when you are changing or initiating or changing a hormone, a method of contraception, think about it. Anything that has got hormones in it may actually affect, if this woman has got an undiagnosed breast condition, it might affect the outcomes at a later stage. When a woman is planning pregnancy, it also sometimes goes around the time when they come in and you remove their contraception, right? They come, you say, okay, doctor, now I want to fall pregnant. Then you remove the implants. At that point, take the opportunity to examine them or to signpoint them to a place where they can get breast assessment, because the importance of that is in pregnancy, breast cancer is difficult to diagnose. It's acknowledged. You can go to the books anyway. It's difficult to diagnose, either clinically or by scans, or even the pathologists, they struggle to diagnose. That's number one. But not only that, it's also difficult to treat. You have fewer of the things that we use to treat breast cancer. You have fewer of those being usable in pregnancy. And typically they come in forms of little windows. Say, okay, from this semester or trimester to this one, don't do this. From this one to this, don't do this. Then you have to stop the treatment in so many weeks, and you have to do a cesarean section and all that. So you limit your treatment possibilities when you are pregnant in breast cancer. So it's important that before a woman falls pregnant, tell them about this risk. And when it comes to assisted reproduction, it goes without saying you attain very high levels of estrogen, and those can feed into, if a woman has got a cancer that is hormone receptor positive, it can get wild. Breast cancer generally, even apart from stimulations and so on, is aggressive in pregnancy. Now you can imagine if the pregnancy was started off by this stimulation, you probably are sentencing that woman to death, if you like. So make sure before the assisted reproduction cycles, stimulation cycles, you have had them examined for their breasts. Right. In the antenatal period, it's also important. Any undiagnosed lumps, get to the doctor. Unfortunately, it's so easy to confuse the lumps of a breast cancer, which generally are painless, and you can also have physiological changes in pregnancy. Some lumps or lumpiness that develops in pregnancy. So it's a confusing arena, but if a woman now says, doctor, I've got this lump that I'm feeling, I'm pregnant, you better have them get them assessed properly. As I said, the treatment is a problem, but even the diagnosis, you can't do, some of the radiological examinations in pregnancy and all that. So get the patient to be examined, and then if there's need for biopsies, those can be done, in a place where the practitioners are trained to do that. Right. You also attend to women at the end of their reproductive cycles when they are affected by the menopausal symptoms. And it is known that HRT does help their symptoms. But you don't give HRT indefinitely. It's also cause for concern. Recommended generally to stop at 3 years. And most of the time, the symptoms would have settled anyway. So if you get a lady who has been on HRT for 5 years, 10 years, that woman you are putting at high risk to develop breast cancer. And in the gynaecology, CA breast and CA cervix have been coined twin evils. So just think about it when you are attending to any woman with any cancer, particularly the CA cervix or ovarian, that that woman also needs to be examined with respect to their breast. And as a matter of fact, there's a common predisposition in a few of the patients for those who have got ovarian cancer. Some of them may actually have a BRCA predisposition problem. So you need to have them examined for their breasts on a regular basis so that you don't miss problems. You may succeed on helping their ovarian cause, but then you lose them to breast cancer. So think about it when you're running your gynae-oncology clinics. And in your consulting rooms, think about, I don't know what you post on your walls if you do, or the materials you share on your tables and so forth. But among all those items that you share with your ladies, think about just putting a bit around breast, a self-examination and all that, and the use of bras, now as the supportive clothing. You may want to also touch on that, because you'll be surprised that many women who visit your rooms, they don't know their bra sizes, and they may come to us complaining of breast pain and all that. So if you have information around the issue of support with the bras, think about it. This might help you, the cause of the women. Just put it in the materials that you give your patients. And in closing, as the trade fair audiences thought we were merchandisers for women's support in the sense of clothing, you may also have that kind of thinking. Is fine. But I'm glad that you have heard of a different bras support that we are advocating for women. Thank you very much.
So thank you very much, Mr. Magara, for your insightful and rather captivating presentation. I think what I just caught was the bras. It's easy. It's easy to remember the mnemonic. Yeah. Thank you for that. I think you also saw that he was a surgeon. He was busy inviting himself to our next symposiums. That's what surgeons do, especially when they see gynecologists. All right. So thank you very much, Mr. Magara, once again for your presentation. I think before we go to our next presenter, in terms of your question, you can hold on to your questions. And then at the end, we'll have a discussion session where we'll call Mr. Magara and Mr. Mugazi to answer the questions, that whichever question we have for them. So our next presenter is a Mr. I've always been confused why some call themselves misters, some call themselves doctors. You'll be surprised the same person at some point is known as a mister. And if you go to another audience, is known as a doctor. perhaps he'll give me some clarification in terms of how do we deal with a Mr. or a doctor. Should we call you Mr. Mngazi or Dr. Mngazi? Dr. Mngazi. So he prefers to be called